Hello, it's Laurie Sullivan here. I just wanted to share a case of a DMEK under a failed PK using preloaded tissue, and just to highlight some of the difficulties if your S stamp is not quite clear enough. I'm starting off with an inferior peripheral aridectomy, as you can see here, just to make sure we avoid the problem of pupil block. Then I'm instilling some vision blue to initially do some staining of the endothelial surface of the host. Here's the preloaded graft, which has lost its trypan blue staining, and also I'm having difficulty seeing any S stamp on there in the cartridge. I figured I may as well start staining it because it's going to help to be able to see the graft margins at least when I'm doing the surgery. I'm just removing the injector from the cartridge here and just rotating it around to spread the vision blue around a little bit more, and I'm just going to add a little bit more vision blue so that we get some good staining of that donor tissue. Now I'm placing some cohesive viscoelastic into the anterior chamber and making my 2.4mm main incision. And with the reverse Sinski hook, I'm going to start scoring inside the graft host junction here and attempt to start stripping the Descemet's membrane. Normally when there's been some corneal edema for a period of time, the membrane will strip quite easily, as you see here. It's not really very adherent at all. Just working my way around on the areas of the graft opposite my paracentesis there, trying to keep the microscope well centered for you to be able to see what I'm doing. This patient's phakic, and we do have a little bit of concern about operating on phakic patients with trypan blue and an air bubble and possible lens trauma, but they seem to do very well, and I haven't had anyone develop a cataract shortly after phakic DMEK surgery yet. I've shifted around with the Sinski hook now to the main incision, and again I'm just gradually stripping from the periphery inwards. We always try not to leave any loose tags behind or when we do this, and you can see that Descemet is stripped off fairly easily, and just removing that with Moorfield's forceps. Performing irrigation aspiration now to remove the viscoelastic and the vision blue from the AC. And there is a little tag there that I'm just trying to capture with the aspiration cannula and remove. And I'm just going to reinstill some trypan blue now, so it'll really highlight any residual Descemet's membrane that I'd like to get out. Just massaging it around so it stains well. And you can see there's a distal flap of Descemet's that I'm just aspirating now and tearing around, and there's also a little, quite a large proximal flap there that I'm just engaging now and just tearing across, or attempting to, with fairly high vacuum, and it's not really coming, and so I get the Sinski hook and just use that to detach that flap. And you can see it's free and flapping from a pedicle now, and I'm just pulling it out with that reverse Sinski hook. I'm just attaching a fluid-filled tube with a syringe of BSS on it to the introducer, to the injector, and I've just aspirated through some clear BSS into that injector. I'm having a good look at the graft here, trying to see where the S stamp is. There is a bit of an S stamp there that you can see, I think, but it's really not easy. And so as much as anything, I'm going to need to use the conformation of the graft and the fact that it that it scrolls with the endothelium on the outside as my guide to how it's sitting inside the eye. There is just a faint S stamp there, you can see, on the left. And adjacent to that there was a small tear that occurred when the graft was being prepared, and that's also not easy to see, but we'll see that later. Just drawing the graft forward into the front of the injector now, trying not to go too far, and then attaching another BSS syringe to the proximal end of the injector, all done under fluid so that we don't get air bubbles as much as possible. This is the goiter equipment as supplied to the eye bank. And you can see the graft there. I'm just zooming in and looking at that scroll. It's a fairly tight scroll in that injector there. But I can see where which way is up and which way I need to turn the injector once it's in the eye. Getting some condensation on the surface of the injector there, the glass tube. Now the AC is being depressurized. It's quite relatively empty. I'm just injecting the tissue into the AC and very slowly withdrawing the injector. And you can see the little tag there just adjacent to the main wound. And I don't really want to have that either flapping around or floating around inside the anterior chamber. So I'm just using the end gripping retinal forceps to try to grasp and remove that. And just tear that off gently. Tapping the graft around now so it's not lined up with the main incision. And I can put some BSS in the AC and then just pass a suture. I always suture these 2.4mm wounds. I have had grafts come out through them before. So I find it much easier to, in a soft eye, to suture from out to in, from periphery to centre, as you tend to distort the wound much less and have much less leakage of fluid or air from the AC. Getting rid of a little clot there in the knot, in the slip knot, which would stop it from slipping, and just now tightening the suture. Now I'm just trying to nudge the graft around to get an idea of its attitude within the anterior chamber. And the only way I can really tell which way is up is by the direction in which it's scrolling at the moment. I cannot really visualise the S stamp in this situation. The full thickness graft there is a bit hazy, so the visibility is not 100%. I'm just tapping and nudging there. I think I can see the S stamp there. I'm just trying to move it so that I can envisage it again. I'm thinking that it might be upside down. I'm not certain. So little jets of fluid trying to shift the graft around. If part of it gets stuck into the angle, the graft won't turn over. It'll just stay where it is. Now I've flipped it. I think I've flipped it. And I'm just shallowing the AC now and pushing the graft across into approximate position. It's actually unscrolling, was unscrolling nicely. Now it's folded up again, so I'll just deepen the hold and tap it a bit. See, I managed to inadvertently inject a few air bubbles into the AC. A few air bubbles is not a big issue, but a lot of air bubbles can be. And I've aspirated any ones that I thought were troublesome. The graft's looking in reasonable position now, and I think it's the right way up. I injected a bit too vigorously there with the BSS. Whilst the AC is pressurised, I'm just burying the knot on the suture. Now I'm coming in with a cannula with some SF6 gas and injecting some air, and you saw the graft there unfold temporarily as that gas bubble came in. Then I've just aspirated it to reassess the graft positioning, and then I'm rebubbling it again on the table. Gently stroking to make sure the graft's not folded, and to extrude any fluid in the interface. A little bit more gas, and the eye is well pressurised. And I'm just indicating here where the edge of the graft is in relation to the edge of the PK graft, and there is a bit of overlap inferotemporally there. Just hydrating the wound and injecting some antibiotic solution as well, and that's it. Day 1 anterior segment OCT with the decimase membrane well attached inferotemporally to the graft, full thickness graft, and the air bubble, about a 60% air SF6 bubble in the anterior chamber. Here you can see the day 1 post-op photo. Sorry for the poor resolution, but you can just make out the edge of the graft overlapping the periphery of the PK there. And here's the before image of the failing graft. And this is day 5 post-op with the graft clearing superiorly and nasally, and still with a small SF6 bubble above. Thanks for watching.